Hey, this is Trin, the Guides Outreach Coordinator and current second year at KCU in Joplin, Missouri. I'm here to announce our Season 2 giveaway. If you're a medical student in Missouri, you can win a $100 Fabletics gift card, courtesy of MAOPS and the YPN, to update your scrub collection. To enter, you'll need to do the following two things. 1, leave us a comment and let us know which episode was your favorite so far. You must comment either under this episode or the previous February board exam episode. And number 2, follow us on Spotify, Apple Podcasts, or YouTube, wherever you left your comment. The winner will be announced in the April episode. Good luck.
So you can still be thinking osteopathically as a cardiothoracic surgeon, as an ophthalmologist, as a pathologist. Like, you don't have to just be thinking osteopathically if you're an FM or an OMM specialist, right? It always should be in the background of how you formulate your thought process as a physician, period, as an osteopathic physician.
Welcome, everyone, to another episode of the Young Physicians Network podcast, sponsored by the Missouri Association of Osteopathic Physicians and Surgeons. My name is Vinny Cook. I am a third-year medical student at the ATSU University Kirksville College of Osteopathic Medicine and a former Osteopathic Theory and Methods Fellow. The topic of today's episode is, what is OMM? And unfortunately, guys, we cannot dive into this topic fully in just a short 40 to 60 minute podcast, but I'm hoping today that you guys are going to be able to get a better understanding of what OMM is, how you can apply it when you're in your rotations, if you're a resident, or maybe even if you're an attending who would like to get more involved in using OMM, get a better understanding of how you can apply OMM, how you can learn more about it, get more educated on different techniques, get a better idea of what routes you could go utilizing OMM in your future as an osteopathic physician. We are joined today by our guest, Dr. Alex King. He is an associate professor of OMM at the Rowan-Virtua School of Osteopathic Medicine. He's also the program director of the Osteopathic Neuromusculoskeletal Medicine +1 program at Rowan, and the medical site director for the Rowan Neuromusculoskeletal Institute in Sewell. He is an up-and-coming osteopathic physician who specializes in OMM, or ONMM is another newer designation. He is heavily involved in social media. He is getting involved more and more at the national level through the AOA and other organizations tied to osteopathy. Dr. King, thank you so much for taking time out of your busy schedule to join us today.
Yeah, thanks for having me. This is a great thing you've got going on. Happy to contribute.
So, Dr. King, before we dive into OMM and the broad field of OMM, I'd like you to talk a little bit about your journey into osteopathic medicine. Talk about where you came from, how you found your way into an osteopathic medical school, and ultimately how you found your way into pursuing OMM as a specialty.
Yeah, I've had quite the journey. I'm actually an artist in disguise in physician's clothes, so to speak. So a lot of times I feel like a fish out of water, but honestly, osteopathy was the one place where I felt most at home in the medical field. So that's kind of where I live now. But, I grew up the son of a second generation physician, my grandfather being an herbalist, acupuncturist, MD from Korea. Most of his kids, including my mom, went on to allopathic residencies and did med school over there, and came in the 70s over to America. And then it was kind of expected that I would eventually, apply to medical school and be a physician. I wasn't always so sure. I was still finding my way, as a teenager and college student. I was like, is this what I really want? And then my pre-med advisor mentioned, hey, you're like a perfect candidate for osteopathic medical school because of my sculpture and neuroscience double major background, which is kind of unique. They're like, oh, so this is like what you really should look into is osteopathic medicine. And I didn't even know how to spell osteopathic, to be honest. I was like, what is this? Like, I'll look it up, and I did my research and it really intrigued me. I really like biomechanics and the musculoskeletal system and using my hands, and it's what I wanted to do. I was already interested in orthopedic surgery and had shadowed surgeons during my college career as a pre-med student. So I applied to PCOM, and that's where I ended up going. And learned from Alex and Evan Nicholas as, two of my major influences in the osteopathic realm, and learned from them and honed my skills as a student and applied to OMM residency at PCOM, which I did for 3 years, and did an acupuncture fellowship during my second year of residency. And then after residency, I worked private practice for about a year until I applied and started working at Rowan about 5 years ago. So that's the quick cliff notes of my background.
Wow. Yeah. I mean, having an artistic background, you mentioned sculpture, right? I know in another podcast you recently done, you talked about, recently how your counselor in college, your pre-med advisor, had just been saying, look, you work with your hands. Basically your entire resume just screams osteopathic medicine, right? But
yeah,
exactly. when you went to PCOM, was there a time? I'm thinking back to as a student, in the lab when you're in OMM lab, and obviously you help teach at school, you help teach the lab, and you're in the lab setting, and you're being taught all these techniques, you're being taught the theory behind the techniques, right? Sometimes it can be kind of a shotgun blast of information, and it can be hard to synthesize how I'm going to use this clinically, right? Was there a moment when you were in your first or second year learning these techniques in your OMM course where you kind of started getting that inkling of, okay, maybe this is something I'd like to pursue in residency, or was that way out of your mind when you were going through learning about this material?
I think initially I was pretty, I had aspirations, and I was somewhat of a gunner of like ortho, and I want to be top of the class, all that stuff. But then what I really enjoyed was actually treating people. So when I learned a lot of these techniques, I was practicing them right after lab on actual dysfunction. Like my fellow students, they would come to me like, hey, I heard you're good at this stuff. Like my neck's been killing me. I'm like, all right, lay down. And then I would just make up stuff. I would do the techniques we were taught, but then I'd be like, I think there's probably a better way to do this technique. And I'd run it by my professors, of course, and make sure I was doing things safely. But I'm very comfortable in a creative environment and in a adaptable type of situation and being flexible in my thinking. So I kind of applied that to OMT and was already trying out things I hadn't really seen in textbooks as a student and coming up with my own techniques and protocols and ways to approach certain dysfunctions. So it kind of just came very naturally. Like it's how my brain thought kind of anyway. And I was just excited to learn what the research shows and what have people done before me and what have they thought about these issues and certain pathologies. So I think the real big light bulb moment was just treating my fellow students after lab and just putting in the extra work. I tell people that like OMM is like a martial art form. It's just kind of a healing martial art where you need to practice it. You can't just expect to be good at like jujitsu and just go once a week or once a month. It's like it's not like that. You got to be doing this every day if you really want to be good. So that's kind of my ideas with that.
Right. And you mentioned after your residency, you went into private practice shortly, and then you've transitioned into academic practice now. What were the major differences between the two? What are the things that you noticed in how you practiced in your private practice versus how you're practicing now in the academic setting?
Yeah, I think there's a pretty big difference in just not just like the work culture of it, but in your day-to-day tasks. In private practice, it's a lot more entrepreneurial, which people like. It's you're marketing, you're looking at the actual profit margins, you have your employees, you have the ultimate flexibility of choosing what direction your business goes and how to serve your patients best with your skill set. It can be a lot for certain people who maybe don't have that entrepreneurial interest or who feel stressed out. I certainly, as a new attending, was like, wow, this is a lot to learn. Like, forget just the medicine, but the business of it. It's so much. Luckily, I had been hired by my mentor, who I was doing rotations with, and so I kind of continued that. But it was a lot of like, listen, if you're not seeing patients, you're not making money. So you really got to find good referral sources and ways to generate that patient influx, which was tough because this was during COVID. So not great timing, and building a practice during a time where no one wanted to go see the doctor, especially one who's right up in their face, treating them. So it was a little bit of bad timing. It was a lot of me like learning something completely new that I'd never had any courses in, like business and running a business. And in the academic realm, I feel a lot of fulfillment from teaching. So, I'm teaching all day, every day, whether it's my own residents, whether it's students, even reaching out to pre-med students who need mentorship. And I find that I like to convey knowledge that has been passed to me, because there's a lot of osteopathic knowledge out there that doesn't get conveyed, in textbooks and, through traditional media. And I think it's important to tell the stories, to show with our hands, to pass on this knowledge to the next generation. So that's why academia, I find, a really nice fit, because it's not only a little less stressful, right, than having to generate business to make an income, but it's also very fulfilling. And, I don't do as much clinical work as I would have to as a private practice physician, where you're really cranking out a lot of patients. With my schedule, I have a lot of administrative time. I have time to do my research. So it's a nice balance, which is why I'm pretty much here to stay. I feel like it's a very nice lifestyle. So.
Yeah, and there's so many directions. A lot of questions I want to ask you, but because my OMM nerd brains kind of go, bells are ringing.
Yeah, of course.
So one thing that you can attest to this, when I was a fellow in Kirksville, I helped teach the course in lab, and obviously you're walking around as a table trainer during lab, and students will commonly ask you, first and second year students, and I had the same questions when I was a first and second year, what does life look like for an OMM specialist, right? What are the different settings? Because people can kind of imagine, okay, I know what an orthopedist is going to do. I kind of know what a cardiologist is going to do, what an internist. But OMM, a lot of students would be like, are you doing private practice, which you've done? Are you doing academia? Like, what does your day-to-day look like? So from your perspective, what do you do in your practice on a day-to-day basis? Just to give students an idea of the variety of your day-to-day practice that is available as an OMM physician.
Sure. I mean, I can give you the hard numbers with it. I've experienced pretty much every type of OMM practice, so to speak. I started an inpatient consult service that I'm doing now for Virtua, which started a week ago, actually. It's been going really well.
Excellent.
So it can really be, and here's why I think it's like the best kept secret in medicine that DOs could think about pursuing, because, we'll probably be the last specialty to be fully replaced by AI. So that's number one. Number two is that you can make it exactly what you want, as long as you're good at, networking, hunting down opportunities. Every DO school just about in the country is looking for board certified OMM physicians. And so if you want to work academic, you could pretty much work and live wherever you want in the country where there's a DO school, which is nice. my day-to-day is really, depending on the day of the week, 3 days a week, I have full patient days for the most part. So like Monday, Wednesday, Friday. And those days, it's about 8 patients per block. So 8 in the morning, 8 in the afternoon. Could be 8 to 10, give or take. But that's because you're seeing patients like a follow-up every half hour, which, to be honest, in the grand scheme of things, as a specialist, is pretty good because you're not rushing constantly. Don't get me wrong, I could probably take an hour to treat somebody, but 30 minutes is a pretty good chunk of time, and you can bill for 10 regions in that amount of time. So your RVUs are pretty good. So I would say it's a nice balance of not being rushed, having time with your patients. You're getting immediate results because oftentimes the treatments, they feel better walking out the door. I still do a lot of needle work. Like, I do a lot of acupuncture. I do a lot of injections. I still prescribe medications and physical therapy. So it's not like you're a chiropractor or anything like that. And you're seen as a specialist. You are regarded as a specialist who has their lane of expertise, and Tuesday, Thursdays are academic. So I'm in the lab, I'm doing my research, I do my admin work. I'm a course director, so there's a lot of creating exams, but there's also, I just applied for like an AOA grant to study OMM. So it's a really nice balance. And if you like varying your day in and day out, I think academic OMT is a really solid choice because you're a salaried professor at that point. But then you have the private sector. So if you just love treating and that's what you want to do, you could see 5 patients a day. You could see 20 patients a day. You could do 2-hour visits. I've seen it all. You can charge, in Philly, Center City, I was charging about $500 an hour for OMT. And the thing is there's almost no supply. So yeah, patients are willing to pay a pretty good chunk of change for OMT, especially if you've got the skills. So honestly, it's like, it can really be whatever you want to make it. So I often welcome questions for people who want to explore what possibilities there are.
Yeah, there's a few things I thought of as you were saying that. First and foremost, I can attest to the demand for OMM, because, even before medical school, I worked as a physical therapy aide and a personal trainer for about 5 years. And I routinely had, and this is in the Bay Area of California, so only one DO school, Toro, in the region, but a lot of our patients, there were a number of them who, they ask you, what are you going to do? And I'd tell them I'm going to osteopathic school, and they would be like, oh my God, please come back and practice here. I've been trying to see someone for manipulative treatment, and it takes 3, 4, 5 months to get in to see this person because they're booked out. I'm sure you can attest to that experience, right? There's a limited supply of physicians available, and there's a huge demand.
We have about, I believe, 8 people in the department that do OMT early at the NMI. They're all booked. They all have multiple months wait list. My residents both have a 2-month wait list as a resident. And so the demand is off the charts. So yeah, it's pretty crazy.
And then the second thing, I remember you, as a side note, bringing this up in a recent podcast you were on. I think it was the DO or Do Not podcast, talking about a patient you had been working with that had came in and you were doing your history and physical. They had like chronic low back pain. And you were doing your typical history and physical, and the patient had mentioned, I've lost about like 10 pounds over the last maybe 1 to 3 months. And they're like, oh, have you tried anything different? Have you been trying to lose that weight? And I think the end of the story was, you did your typical workup on this patient. Turns out they had Mets from prostate cancer. The reason why I bring this up is I think students will get that misperception that every OMM specialist or every physician that really utilizes OMM heavily in their practice, they want to be just pure manual medicine. They don't, they kind of view it like we're not still doing all the typical H&P, ordering the labs, ordering the diagnostics, et cetera, that we would do as osteopathic physicians. And then, third tier on top of that, you have the background in acupuncture. You mentioned the needling. Seems like there's a lot of room in your practice to integrate a lot of things to add to your OMM skills, right? You mentioned the acupuncture, needling. I'm assuming some dry needling is in there. Injections, if I'm not mistaken, probably even room for, biologic treatments like prolotherapy, PRP. Right? So PRP, et cetera. Is that something that you're seeing more physicians that either specialize in OMM or do a significant amount of OMM in their practice? They're starting to integrate those other facets of care into how they approach their practice?
Yeah, my mentor definitely used a ton of prolotherapy. I learned PRP from my other mentor when I started in private practice. I also learned prolozone and ozone treatments. So a lot of orthobiologics. But now that I'm at the NMI, which is an institute, we have a sports medicine specialist who does a lot of ultrasound guided orthobiologics. So I kind of have my lane, which is the ACU-OMM, and then I refer people to him. He's got way more practice, but I did used to do it. So I would say any really solid OMM specialist is going to have multiple tools, whether that's multiple OMM modalities, let's say like FDM, LAS, they're a good cranial person. You can also stay in that single lane of I just do cranial work or I just do biodynamic work, which is totally fine as well. I like to offer more OMM along with an energetic focus towards acupuncture and trigger point injections, neural therapy, which is more done in Europe. But I really like palpatory guided injections. I don't do any ultrasound, but I also know a lot of OMM docs who do a ton of ultrasound. Like shout out to Dr. Kozar at VCOM. He's like a massive MSK ultrasound guy. He's insanely good at it. So I think what's really cool about OMT, just like with martial arts, is like there are these masters who have their own style and who can teach that style, and it's unique to them. And if it resonates with you, that's what you pursue, and that's where you train, or that's how you help your patients. So I think I have a ton of different tools, and then patients get referred to me to try those tools, especially for the combination of Acu with OMM, and I just see if I can work my magic with those patients. So.
Yeah. And, I should have started out this whole podcast, right? Because the topic is what is OMM? And here I am, I'm nerding out. I'm talking about OMM and not even giving a definition to viewers. Now, osteopathic medical students hopefully will know what OMM stands for, what it means. But let's say we have the odd listener who doesn't know what OMM is. Say they're a pre-med. How, say you have a new patient or you have a pre-medical student, and they were to say, Dr. King, what is OMM? What is the philosophy? What would your answer be for them?
My answer would be, I think the better question is, what is life? Because that's easier to answer. OMM it can be many things. I think if you look in a textbook, the definition is, it is a manual manipulative treatment performed by an osteopathic physician or an osteopath, depending on the country that you're in. Who's had training in the tenets of osteopathy as well as techniques that treat somatic dysfunction. Then you have to say, well, what is that? Well, somatic dysfunction are areas of tissue texture change, tenderness, asymmetry, and restricted range of motion in the body that can cause pathological disturbances in the balance of your normal physiology, let's say. And that's a mouthful. And then they'll look at me and be like, what did you just say?
Right.
So the way they're really, like if I was describing it to my 2-year-old daughter, right, I would say we put our hands on someone and then we use our intention saying, I really want you to feel better here. I hope you feel better, knowing what I know in anatomy, physiology, and osteopathy. And then that patient will then therefore hopefully start to feel better because of the hands-on touch that we provide and the knowing innate kind of, and then I go down the whole rabbit hole of quantum physics and cybernetic loops, et cetera, et cetera. But that's how to explain it on the most basic level is one human touching another human. Something happens to then create a harmony in that healing process. It starts and it makes them feel better. So it's kind of it.
Yeah, and it is, you're right. It's like a mouthful, right? And we're throwing specific words. We know what these words mean. I still, will get second years that would come up to me in lab and they still wouldn't quite understand what somatic dysfunction represented, because they're probably just trying to learn the techniques in lab, they're not really diving into the philosophy of it.
And I could go down that whole rabbit hole of why I often don't like techniques at all. But anyway, AT still is like never taught techniques, right? You taught anatomy and principles. Yeah.
Yeah, you're not the first person that has said that to me. I think out of all the conversations I had at AAO Convo last year, that came up over and over again, that theme. But I digress. So then the next question I think students would ask me, and I wouldn't know because I was a fellow, I'm not a physician, right, is, okay, so where does OMM fit into your patient's plan of care? Yeah. What are its indications for use? Yeah. How would you answer that? Very broad question.
Well, I think it's almost like it always should be in the background of how you formulate your thought process as a physician, period, as an osteopathic physician. So you can still be thinking osteopathically as a cardiothoracic surgeon, as an ophthalmologist, as a pathologist. Like, you don't have to just be thinking osteopathically if you're an FM or an OMM specialist, right? Because that's where like, oh, those are the people who do OMM. Like, yeah, they can be doing those techniques, but thinking osteopathically doesn't have to be relegated to those specialties. Like if you have the letters DO behind your name, that level of thinking should always be there when you're diagnosing, when you're treating, when you're coming up with a plan. Their mind, their body, and their spirit should be a component of how are you going to help this human being. It doesn't necessarily have to be, how am I going to adjust this person's neck or their thoracic spine? It's like, yeah, maybe you refer to someone for that, but you can still be making osteopathic considerations, as an OBGYN who maybe had a patient with multiple C-sections, which could explain their back pain. So it's a way of perception that I think people or students and pre-meds, they might kind of oversimplify, be like, oh, you just do the hands-on OMM stuff. That's just in a separate little box and it's added onto the exam you got to take, and then you're done. And then you just go and be a real doctor, right? It's like, no. This is not what we're doing here. This is not how it was meant to be perceived or taught. So, yeah. That's
a great answer. I mean, I know you brought up another patient example. You talk about C-sections and OB, right? You talked about another patient you treated that, and how I don't remember getting a lot of this in my curriculum, which is how to deal with treating scar tissue, right? So talking about like C-section scars, for example, right? You can probably think of having that perception and that approach to care, you can carry that into any specialty you want, right? And though kind of layering on that, what type of patients do you usually see in your practice, right? I know every physician is going to have a different population based on where they practice, what their focuses are, but what types of patients do you treat, generally speaking?
It's kind of interesting in that what I found is existing in a system that doesn't really know you exist, you end up treating blind spots. So granted, there is a commonality to the patient panel of an OMM physician, like back pain, neck pain, sports injuries, things like that, your basic stuff. But then what you realize is you're going to start to get patients who fall through the cracks of the standard healthcare system because you're their last chance. So in that category, you get a lot of patients with fibromyalgia, chronic regional pain syndrome, hypermobility type syndromes, really weird. I got a Portuguese man o' war sting on my list. Patients where 5 neurologists will see them and be like, I give up. Like, I just go see Dr. King. Like, that's all I can say. And they're like, who is this guy? And they're like, I don't know. Just go see him. I know he does some stuff and they do well. So a side effect of living in this kind of like structured and hyper specialized healthcare system is a lot of these patients with very complex neurological and musculoskeletal presentations will just not be able to find someone who can truly quarterback their situation because of the I guess, the integrated kind of pathology of their complaint. So let's say a hypermobile patient, that hypermobility is going to affect so many systems that they're going to be bouncing to a cardiologist, maybe a neurologist for their dysautonomia, maybe a chiropractor because they just feel like they need an adjustment, maybe a massage therapist and their primary. And none of these people are really addressing everything in a holistic fashion in the way that it should, because they're maybe not thinking osteopathically. But if you see an OMM specialist or someone who thinks osteopathically, they could handle a lot of these systems and make the patient feel understood and feel better and give them answers, which honestly helping them understand their body actually gives them a lot of relief, right? Because it's like they've been told, no one's been able to tell them why they feel this way, what's going on, why their heart is randomly tachycardic, why their skin breaks out in all these itchy spots because of mast cell activation. Anyway, so what you get is a patient panel that can be challenging but super rewarding to treat, because then once you help them feel better, they're like, you're the only person who's been able to help me. And you hear that a lot as an OMM physician because, you kind of see the tough cases. But I think that also makes you a much better physician, and makes you really proud of like how you're able to help your fellow humans. So.
Yeah, that's a great example. I remember in Kirksville, as fellows, we spend time obviously early on rotating with all of the OMM faculty, and then we have our own clinic days as well as fellows. And I remember when I first started shadowing, just how many patients fit exactly into that description you just described, where they've seen 5 or 6 specialists, they've got something autoimmune going on, they've seen a rheumatologist, right? They're seeing a neurologist, they've got chronic headaches or migraines. And the unfortunate thing with among many things with these patients is that narrative that has been kind of put into their minds of, I'm broken, something's wrong, no one knows what to do to fix all of these problems. And I'm just kind of presenting at your clinic looking for some guidance, some hope, some help, right? And I feel like there's so much room overall in medicine. I don't want to get too preachy, obviously, but so much more room for that, because like you just described, as a physician who utilizes OMM in their practice, you might have that opportunity, not always, but you might have that opportunity to have 30 minutes, right, with a patient. Which, how often does a PCP get 30 minutes with a patient, right? I mean,
never.
One in
it's like
one in a million,
average.
Right? Yeah, right. Yeah. So you get that opportunity to really dive into this patient's history, which you've already talked about on another podcast, where when you first see a patient, right, you spend about an hour and a half with them. You might spend a third of that time just getting to know this person. I mean, that patient probably can't might have never even had an appointment in their life where they've had a physician just spend 30 minutes just asking them about all the facets of their health, right? And there's definitely healing just in that alone, being heard, right? Having a physician say, this narrative that you've been propagating or has been, taught to you is not true. You're not broken, right? It's just a consequence of a very sectioned out medical system we have here, right? Where you bounce around to specialists and they only have a piece of the story. And then when the patient comes to you, you have to piece all of that together and try and just find solutions, right? Try and treat the whole person, which I mean that is a core component of being a DO.
You're listening to YPN's Guide to DOing Medical School. This podcast is hosted by the Young Physicians Network of MAOPS, the Missouri Association of Osteopathic Physicians and Surgeons. MAOPS has been the voice of osteopathic physicians in Missouri for the past 125 years, advocating for the osteopathic profession at the local, state, and federal levels. This podcast is created for students, by students, to help with the unique struggles of medical school, tailored to the osteopathic experience. Have a topic that you would like to hear about next season? Let us know at our social media pages. Instagram @DO_MAOPS, and Facebook Missouri Association of Osteopathic Physicians and Surgeons. This is YPN's Guide to DOing Medical School.
I was going to ask you, what is your common approach? Maybe not common, but how do you like to approach when you're working with patients, right? Obviously you're doing your H&P, but do you have a kind of an approach, top-down approach or bottom-up approach that you like to take with patients when they're a new patient that comes to see you, aside from just reviewing, their history and their background?
Yeah, I think in evaluating a new patient, I like to take I call it just like a team approach, because often what happens is I have very different tiers of people I'm working with. So I'll have like a higher level resident, maybe a fourth year doing their elective with me, a couple third years who are on their rotation, and maybe even a precepting first and second year. So I've got like 3 or 4 levels of different expertise. And so I often will just have the students go do the intake, and the resident join them, and I'll be like, all right, just keep an eye. If they miss anything, maybe just hop in and teach them something. Or so I just kind of am in the back, reviewing the chart, seeing the progression of this person, what they've had in the past. And then, once they go in, evaluate and ask their questions, and they'll come out, present to me, I'll try to get a sense of what they did on their physical exam, if they're asking the right questions, if they forgot certain questions. My favorite thing is asking a question that I know they probably didn't ask, and then seeing them squirm a little bit, be like, we didn't touch on that. Or they'll never say oh, I just forgot to, or I didn't ask. I always love to see what they come up with. But anyway, and then it's a teaching moment. I'm like, okay, maybe I would have asked a little bit more about this imaging finding, or maybe go into that epidural injection that maybe didn't work out so well, and why, what happened there. And then once I do a little bit of that, then I'll talk to the resident and just say, hey, did you see anything that I'll kind of ask, what are you going to do? Let's say you're the attending now. What's your plan? And they'll tell me maybe some physical therapy, treat them here, maybe have them come back in a month. Maybe I'd order this medicine or this imaging, etc. So I'll kind of do a Socratic method type thing of have my own vision and plan for what's happening. And I try to, in my mind, construct this mental image or picture or story or movie of this patient before I even go, just to see if that matches up. And if there is a mismatch, then I'm well, why did I have that mismatch? And then that will tell me what I need to hone in on, and where there's either blank spots or kind of gray areas or confusing parts of this presentation. And oftentimes those things will tell me what we need to do or what's been missed that needs to be kind of focused on. So then I'll go into the patient room. I'm a huge believer in history and physical diagnosis. I really, really, really like to just be a detective. I ask a ton of questions. I even think about the way they're answering the questions, who this person really is, and try and figure out. And I put a lot of weight into behavioral patterns, occupation, lack of occupation. That's the spirit component, right? Is what is this person spending their life doing? Is this having an impact? And most of the times, yes, it does have an impact of why they're here. And so I just spend a lot of time yapping. I love to talk. So I just yap. And then I'll just kind of transition into, okay, palpatory experience, physical exam, checking their, verifying what my students have examined. And if it doesn't match, I teach. I'm like, okay, they are actually a little hyperreflexive. So I wouldn't give them a 2, I'd give them a 3. See this is a Hoffman's reflex. They might have a little positive, they might have a lesion in the upper motor neuron. And then checking, osteopathically, right? All at the same time. So I'm always palpating, always feeling for areas of compensation, restriction, asymmetry, etc. Observing, right? I always look at the skin, always look at the area where they're complaining. Never just say, yeah, it's probably not shingles. you gotta look like you just have to. Plus, I find scars that way, scars that they've forgotten about that actually look pretty gnarly. I'm like, yeah, this is a problem. They're like, oh, well, that was for my surgery 30 years ago. I'm like, yeah, but does it hurt if I like poke on it? And they're like, actually, yeah, it does not feel good. And then osteopathically speaking, when I do my OMT, let's say I clear any contraindications out there, I'm like, they're good to go. Let's get into treatment. I've always been one to start at the feet and work my way up. That's just how I was kind of taught. Some practitioners in our practice will do middle out. So they'll do, treating anominate first and then kind of progress down and then start anominates and work up. So it kind of depends on the flow you like. But I'm a big foot up kind of person. So it's probably the longest way to answer your question.
No, that's great. I appreciate it. And look, I threw you a very general question, right? How do you go about doing your general physical exam for every single patient?
Give you a 15-minute answer.
No, I appreciate that. I think something I got caught up with when I would, be treating patients or co-treating patients is I think from my background, I'm so focused, maybe too biomechanically speaking, right? So, I love muscle energy, facilitated positional release, right? All of those techniques. I just, big on improving range of motion and blood flow. But I feel like there's got to be other students like me that you've seen where we come in and we're maybe too narrow in what we're trying to use our OMM for, right? We're not getting the big picture of the patient. You talked about understanding, what does this patient do for a living? Do they work, right? What do they do for work? What's their family life at home? Where do they live? Like, all of these things factor in. You mentioned the personality side. I'm sure you have that experience with Eastern medicine that I probably won't be able to get into, but you have that background and that background in acupuncture, which you probably integrate into that history, like you just mentioned, right? Getting a better idea of what's this person's persona, right? How are they going to respond to treatment? Do they want something fast? Do I need to inject them, right? Or is this someone where, I need to do a few treatments and they better be seeing results, or is this someone that's in it for the long haul? Yeah. I gotta imagine there's more students like me that come in and they're like, oh man, I'm going to show Dr. King, my HVLA is perfect. He's going to love this, right? I mean, we've got to be a dime a dozen. You come in and we think, we're going to do all these techniques and it's the technical prowess that's really the base of the pyramid. But, and it, maybe it could be for some patients, right? But I'm curious if you see that when students come in, or even new residents who've chosen this path, where they're just too narrow in their scope with how they're trying to treat these patients.
Yeah, I'm the most impressed by conversational prowess, by students who you can tell have spoken to a lot of different kinds of people, not just their peers, not just other, med students the whole time, but like a student who can communicate with like a Vietnam War vet who did construction their whole life, who's like, maybe rough around the edges, but like can truly like resonate with this person and find out what's been really hurting them deeply. And then come out with a good treatment plan for that person, even though they might not agree on anything from religion to politics to whatever. But like, so for me, it's almost like being this like chameleon in all these different situations in a way that patients can then, you earn their trust to kind of bring them to a whole new level of health and to feel better. Cause I'm like, you can read Nicholas and learn the techniques and do them perfectly and but like your patient still might be like, this guy is like, I don't really like this doctor, so it's, I really appreciate the students who are actually non-traditional, who've had completely other careers, who've lived, lives outside of medicine and who can bring that to the table, because those are the intangibles, that I think really can create amazing physicians, or like the most humanistic physicians, because that's really what we need. We don't need more AI. Like, we don't need more robots. And so we need people helping and healing other people. So I'm impressed by students who are maybe not quite as, I'm trying to look like formal. Like I'm not a super formal person. What I care about are the patients. Right. So yeah.
No, that's a great answer. And textbook osteopathic schools, right? We've been well known to really be accepting of non-traditional students who have that background, who are very socially averse, and can really take into perspective, maybe almost look into what it's like in the patient's shoes. What it's like to work
100% being
a
empathetic.
work a 9 to 5. Like, how many med students have just gone right through, and never even had to get up and work a full 9 to 5 day. There's a lot to be said for that, and I could go off on a ton of tangents, but no, I really appreciate that thought. I wanted to transition a little bit because, I don't want to take up too much of your time, and I feel like I could pick your brain for hours, but in your mind, as I was going through my school, I obviously chose KCOM because I really wanted the OMM education. That's really why I went the DO route, and particularly KCOM, because I knew I wanted to use it in my practice. And with my background, in physical therapy and personal training, the fitness space, I just loved the manual side and the integration of exercise, prescription, et cetera, into my care. But a lot of students don't share that sentiment, right? What do you feel like the current state of OMM is in clinical practice in the U.S.? Do you feel like it's slowly gaining popularity? I know you'd kind of touched on this in another podcast, but you're someone that's really kind of at the forefront of bringing more attention to osteopathic manipulative medicine.
I think that's a really good question. I think there's a huge potential. And that's why I'm trying to work as hard as I can to just spread the word about it, because I think Gen Z, Gen Alpha are really primed for this type of medicine. Whether or not they become OMM specialists, it doesn't really matter to me. But as long as they are osteopaths and think osteopathically, I think that's ultimately what's going to save healthcare. And it's really good to see that, yes, there are more schools every year, more students are, more DO students make a chunk of the medical student, cohort overall. But I also don't want that to mean there's a watering down of our teachings and our heritage either. So I think it's a balance of, yes, promoting osteopathy and osteopathic medicine, making sure there's more accredited schools that are doing a good job of teaching and passing on this knowledge, but not just to print more people with DOs on their name. Like, I want these, new DOs to actually be osteopathic. And so I think that's why it's so important that we maintain more and more accredited OMM physicians who are board certified every year, because those are really going to be the stewards who pass on the torch to these DO schools that are giving DO degrees. Because without that strong OMM specific faculty at these newer schools, the next generation of DOs aren't going to have as strong osteopathic foundational knowledge. And, they're going to pretty much just be MDs wearing DO, white coats, right? So I think there's huge potential. I think the current climate is in a transition phase of kind of the old guard or the masters transitioning a lot of their teachings to, those people who, like, I'm in my mid 30s, those of us in our 30s and 20s who are kind of getting into the actual workforce as attendings. So I think it's kind of like this unique transitional state where you're seeing the rise of AI and tech, who's threatening a lot of what physicians are at their core. And that as osteopathic physicians, we need to rise to this challenge of maintaining the humanity of the healthcare we deliver, along with the younger generation and their values coming into play. And they're going to be applying to medical schools now too. So I think the main thing that to make sure this goes well is to educate. It is to put ourselves out there in a way that is just completely honest, unfiltered, telling them the truth of what a practice looks like as someone who does this for a living, and then let them decide. Like, hey, this is who we are. If you want to join us, awesome. If you don't, that's fine with us. You can do what you want to do. But I think right now it's certainly still super niche. And I think it always will be. And I actually don't know if I want it to be insanely common in mainstream. Actually, that's a lie. I do. I do want it to be mainstream and common, but I just worry about the quality, right? Like I don't want us to just have, I think we will hit 50-50 with MDs and DOs in terms of the numbers in the next 20 years. Mm-hmm. And when that happens, I just really want us to preserve our osteopathic heritage and how we think. So.
No, and I was a couple of questions I was going to ask. You kind of just answered them, which is, what do you want to see for the future of OMM, right? We want to maintain our heritage. We want to maintain the values, the philosophy that really makes us distinct. But also at the same time, right, we want to improve awareness of OMM and really give, and you're obviously one of the people that really one of the physicians that's doing that the most. You're active on YouTube. You're very active on social media. That's how I found out about you, Dr. King, was actually through Instagram. And I think I've seen it myself with physicians that are transitioning out of practice. They're a little bit more, and understandably, right? They're hesitant to promote themselves, promote the profession, promote OMM, but it is really, really vital. And I'm glad you touched on that because I think, it is very niche still, but it is a very well-kept secret. And I just remember thinking that throughout my training, I was like, man, I don't know why more students don't see the value of learning this. I don't want to call it a toolkit because OMM is not a toolkit. It's really a whole philosophy and how you treat and how you approach medicine. But, I mean, look, I guess the way I look at it, if you get even a fourth of the class to be interested in utilizing OMM, right? You're not going to get a fourth of the class to go into nephrology, right? You're not going to get a fourth to go into cardiology. So that's pretty good. But I think getting that awareness out through people like yourself, I have to thank people like you for doing that because it is vital to our profession. And I do think a lot of students, if they were able to, have a discussion with someone like yourself who can really explain all the intricacies and all of the different routes you can take with OMM, we would have more students and really more physicians that would want to utilize it. But at the same time,
I think that's why mentorship's so important. And I think it's difficult because there's a paradox of like not knowing the value in it until you're already doing it and are a master or are like practicing it. So it's like, I'm like, great, I'm here. I'm loving my life. I feel like I actually don't work. I just get paid to do what I love to do, which is everyone's goal, right? And I just want to like tell everyone I know because I'm like, this could happen for you as well. If you have the right mentor and the right mindset and the ability to make good decisions. But it's tough because it's like, you're not there, so you don't really know. And you just have to like take a leap of faith sometimes and just trust. But that's why, I like to mentor students, even if it's not going into OMM, even if it's like finding what their real passion is and what they want to go into to achieve that ultimate goal of like having fun every day rather than think of it as like dragging yourself to work. That's why, the mentorship angle is so important so that you can prevent the future physicians from being burnt out, from making the wrong choice for themselves, for regretting decisions, because there's certainly a lot of misinformation that's presented. And I think the best way to do that is to just like do things like what we're doing is just like honestly answer questions, talk about my experience and see if it resonates with people. So.
Yeah, I completely agree. Last question, because I know you've got to get going. But kind of closing out this discussion, how can osteopathic students, how could maybe residents or even now attendings that are removed from their training seek more training in OMM, right? Whether that's going back for a residency, whether that's doing a +1 year, which you are a program director of, or even just continuing medical education. I know in Kirksville, we always have every year, we have not Founders Day, but a CME where we have even allopathic physicians come in and we teach them, a shotgun blast of OMM. What would you recommend for students and residents and physicians who would like to get a broader education in OMM to potentially use it in their practice?
Yeah, I would first examine your goal. So, right, if your goal is like, yeah, I want to actually bill and code for this and like do it for my patients, then I would actually reach out and look at going to convocation every year, taking courses at convocation, which is actually coming up in a month. So that's great timing. Really networking with other specialists and other providers who have been doing this. And then you can maybe even get clues and tips about, what your goals are, if it's billing, coding, getting reimbursed type of thing. But if you're just like, let's say you're just a student and you just want to get better at certain techniques, then it's about working with the SAAO at your school, right? Going to their events and their clubs, and they're definitely going to have faculty teaching you techniques maybe they didn't teach in lab that are actually really useful, and it's like the secret sauce kind of thing. And then if you're a resident, and let's say you're like an internal medicine resident, and you're like, listen, I don't know if I really love IM anymore, I'm getting burnt out, but hey, I heard there's this +1 program and they're all over the country, and maybe I could pivot and do that +1 year and get a board cert in OMM and teach OMM at a COM. So, and I have seen that a lot. I've seen people make these career changes and do a +1 and totally pivot. Yeah. So, I would figure out your goal, figure out your why, and try to structure those changes through approaching an organization at the level you're at. So like if you're an attending, think about AAO, convocation, networking with other attendings who are already in the field and who are, have a lot of experience, taking courses. Maybe you do want to get your board cert and do a +1 year. Some +1 years offer you to do it in an extended way so that you don't have to take as big of a pay cut, so you can continue working and then also be a resident at that same time and just kind of extend it so you don't have to fully commit, right? But it depends on the program. Mine does not have that, but it exists. And then if you're a resident, working the RAAO or the resident AAO, and then being active, you can also go to convocation. Really, as students too, I would highly recommend going to convocation. Really, anyone should go. Yeah. It's such a fun, unique experience. It's very different than a typical medical conference. It's way more like chill, hands-on, and way better. It's like more like going to a family reunion every year. Honestly, it's not like going to some dry medical conference. So that's kind of how I would approach it. Is like, got to figure out the goal, and then the most the resources through an official channel to get you that experience and to approach board certification if you really want to take it to the highest level. So
awesome. Thank you so much. Yeah, that is great advice. And I know for myself, I'll certainly be thinking about that, and thinking about friends too that have asked me that, or even attendings now when I'm on rotations. That I tell them, hey, I was a fellow. I absolutely love OMM. Could I use this on your patients? And then they watch you do it. They're like, man, I'd love to learn about that. Or even
like,
just
can you treat me next?
That's the common. All the staff will kind of poke their head in and be like, what's he doing over there? Yeah. No, that is really great advice. And last question. This is, I promise, the last question.
Oh yeah, sure.
Dr. King, where can everybody find you? Right? What are you on? I know you're on social media. I think you're really doing amazing work for our profession, so thank you. And I really want students to connect with you, and also other people that you might be able to network them with, to just help expand our awareness and our use of OMM in our practice. What's the best way to get a hold of you and find you on socials?
Yeah, so Dr. Alex King on YouTube and Instagram. On Instagram, it's separated by little periods, and then doctor is spelled out, so dr.alex.king. I try to answer DMs when I get them. I do get a handful sometimes, but I try to make my way through them and answer them. And then on YouTube, I do read the comments, try to answer them in each subsequent video. I got to put one out probably this weekend, Valentine's Day or something. But I try to do every week or a few weeks, like a podcast just about my thoughts lately, about patients I've treated, random ramblings in terms of that. So somewhat of like a solo pod situation. But yeah, so Instagram, YouTube. I know TikTok is off the chain, but I'm too much of a millennial, elder millennial to worry about the tickety tocketies.
Me too. Yeah, me too.
But maybe in the future. I don't know. I just stick to YouTube and stuff. But yeah, those would be the best ways.
Awesome. Well, thank you so much for your time today, Dr. King. Everybody, thank you for listening. Please go ahead and follow us, the Young Physicians Network. You can find us anywhere you listen to podcasts. You can also connect with MAOPS online through social media as well. Have a wonderful rest of your day, everyone, and take care.